Okay, happy Sunday, everyone. I'm going to be posting now the second part of the lecture. There's going to be 3 of them today. Well, technically 2 today, the one that you're watching right now. And then yesterday I posted 4 videos from YouTube that I thought did a really nice job, again, for those people who are visual learners. I know it's in the book as well, but to actually see it and have somebody explain it, and that was really good, especially for the rules of 9. So I posted 2 videos on the rules of 9, and the first one had to do with adults. The second one had to do with children. So, and infants and children are counted as the same as far as when you're accounting for how much a percentage of the body is burned. Just as a side note, I think I may have written that on there, but just wanted to clarify in case there was any confusion. And then the third video had to do with, I really, really liked this video because it really depicted, again, we've seen a lot of probably pictures of burns. I would imagine not as, for example, like a pressure ulcer, most of us have seen at least a stage 1, right? Burns we unfortunately have not probably been as exposed to, unless obviously we burn ourselves or had a sunburn, or maybe not something as deep of a burn. I might be wrong, but it's much less likely in this part of our education. Unfortunately, we don't get to see it that much. So I wanted to give you a good picture of what it really looks like, and I think that they depict that really, really well. And then we had the fourth one, which was just kind of a nice overview. I wanted just, again, for the visual learners to get that nice overview. So I hope that you did watch that. And I did make a little note that said, this will benefit you if you watch it before the quiz. So you guys do have a quiz today that opens at 5, as well as your test for integumentary. It's worth 50 points, just as a side note, even though there's not 50 questions. Some of them are short answer. And in the future, I think I'm only going to do 25 questions. I don't know, maybe I got excited, and it's a lot of questions to come up with when it's only a certain amount of a section. So we'll kind of depend on how many chapters are in that chapter. So I just wanted to kind of get some housekeeping things out of the way for those of you who may not watch the video that I will start posting as of Monday. We had a discussion last week of how we're going to spend our time so that it's not a repetitive me re-explaining or lecturing on whatever topic is happening. So we'll do NCLEX questions, I'll pose questions, I'll answer questions, and then I will actually post it. I know I keep saying that, but now I actually will, now that we have a plan. So, okay. I wanted to start off the lecture by just mentioning that burns are something that are it can be very difficult, like I've mentioned, with any type of nursing in the nursing fields. We're all, good at certain things, or can place certain things in our body that we're okay to work. Some people can work in NICU. Some people can work in labor and delivery where babies might not make it, or, they're able to house that in their body in a healthy way, hopefully, and be able to cope. Burns definitely would fall into that category. Absolutely. This is a very psychosocial, a lot of therapeutic communication, depending, of course, to how bad the burn is, which we will discuss in this lecture, or in the first and the second part of the lecture, and as well as, obviously physical, and whether it's a first or second, third, fourth. And I wanted to make sure that you understood. I think it mentions it in the book, but if it doesn't, I really, really want to stress, and I do have a PowerPoint as well, but I wanted to get a couple of things out just in case it didn't fit, that I find very important, is really understanding that psychosocial aspect of treating somebody that is in a burn unit. So if you're in a burn unit, that's not, you burnt your finger on the stove, you need a little bit of salve or whatnot to, maybe help your finger heal or whatnot. That's a 1st-degree burn or whatnot. I'm talking potentially, second to 3rd-degree burn, 4th-degree. And a lot of the times when it gets to those higher degrees, even a 1st, 2nd can be mixed. It's hard to sometimes get that definitive, it is a, full thickness burn. It's not always 100%, right? I mean, if you can imagine something, if somebody, let's say, had a kitchen fire, they're cooking something and all of a sudden oil got on the burner and boosh, a big flame came up and burned, let's just say their arm just happened to be there and their arm went up in flames, and unfortunately they had oil on their arm as well because, you know, whatever happened, their arm is now on fire. It's not going to burn evenly. So not every part of the arm, this is something I think is really good to keep in mind. It's not a black and white answer all the time. So it's not always going to be, okay, this entire arm is a 3rd degree burn. It could be that, and as we know, when we have a 3rd degree burn, that's when we usually don't feel any pain. And I always say, I'm not a black and white person in general, obviously, usually, because I think that a lot of the time there is some gray area, right? And in this, and maybe you might want to pay attention to this part, well, hopefully all the parts, but this part in particular, when you have a 3rd degree burn, and in the video that I showed you, the 3rd video that I posted yesterday, it does talk about that one, 3rd degree burns having no pain, which is true. The nerves are, the receptors in the nerves are basically burned. So if those aren't there, you're not going to feel pain, which in a way is good, right? I mean, because imagine when you just burn your finger on the stove and you're taking like a shower or you wash your hands and you act like you're, at least I do, like my whole finger just got cut off, right? I mean, it hurts. Burns hurt. And what I do want to mention again is that it's not necessarily going to be, okay, yeah, no pain. It's good just to kind of remember that as a general rule. Okay, 3rd degree burns equals no pain, so that you can kind of remember that. And then 4th degree would be pretty much 3rd and 4th are the same, except bone is not involved and muscle is not involved in the 3rd degree burn, but in the 4th degree burn they are. So they're very similar in that way. However, I don't like to say no pain, because what if this part of the arm from here, this nice little square here, is a 3rd degree burn, so I'm not really feeling a lot of pain, but then from here to here to here and a little bit over here and a little bit over here is more like 2nd degree burn, and then I have a little bit of a 1st degree burn over here just from kind of flashback, and then 4th degree burn right here. So I mean, you're going to feel some pain. So I just wanted to make sure just to kind of keep open-minded and that critical thinking aspect of, it's not just it's this or it's that. So most burns, when you're on a burn unit and you have a burn victim or patient, I tend to use the word victim. I don't know why. I think it might have to do with the different types of burns that I wanted to mention as well. Again, right now I'm just kind of spitting out random information, and then we'll go through the PowerPoint, excuse me. Okay, so I really wanted to hit on that physical and psychosocial aspect. This is, I mean, a devastating, the amount of people that I have at least, you know, interacted with in my career, it's been few that have been people who have had burns that have been, you know, not just, and not saying that somebody that has a scar that's this big is not going to affect them. We're all different, and we can all, of course, you know, be respectful of each other. That maybe really bugs them because maybe they really like their hands, or maybe they're a hand model. I don't know. Burns to the face definitely tend to be, from my experience, either accidents. So of course there's different types of burns, which we're going to talk a little bit about. I think when we think of burns in general, we think of flames. So, you know, fire. But of course there's the chemical burns, which from my experience and what I've seen, at least in my, I think it was my master's program, we did a lot with this in community health, I believe it was. And it had a lot to do with violence. So there was, you know, and I'm sure you guys have seen this in movies too, but this is probably where they got the information that people will take, you know, acid and burning chemicals and splash it on people if they're trying to, you know, if they're angry with maybe it's domestic violence or a fight, or just maybe someone is psychotic, what have you. As well as people that work in certain factories or certain, doesn't have to be a factory, but just working in certain areas where they use chemicals, and you can get a chemical burn. You can get a chemical burn from wax even, I mean, right? So these are other concepts to consider. It's not always a flame. It can be chemical, it can be flame, electrical, right? What about, it's about to be that time of the year, what's that stuff called? Lightning, right? And then there's one more, I always forget it. Radiation. So people that are unfortunately going through cancer treatment and they're getting radiation done, that actually does burn your skin. If you're not familiar, I'm pretty sure you guys, since this is the last semester, you guys have gone over radiation, but it will burn the skin and you will have like a sunburn, right? So these are just different aspects to kind of keep in mind rather than just, and I'm going to be really honest with you, even when I was reviewing, of course I reviewed the chapter before I go over it, because the books do change, and I had a very similar book a very long time ago when I did this program, but I was even kind of, it took me a minute and I went, oh yeah, duh, there's other types of burns, because I just automatically think, oh, burn, fire, and that's not the case. And all of those burns that I mentioned, I try to anticipate questions that I might get on Monday, and I was thinking about it. And something to consider is that if somebody were to get an electrical burn, so for example, again, we're going to get further into it, but I'm just kind of giving you an overview of what we're going to be talking about, is that if somebody does get an electrical burn or chemical burn or whatnot, actually, let's stick with electrical, because I think electrical and flame, fire, they're not the same, right? One has actual fire coming at you, the other one, electrical, it goes, and there's like an entrance point, if you will, that those actually do. I can just imagine the question of somebody asking, well, could that affect you the same way as a fire would affect you? And absolutely, it may not be as, depending how bad it is, it may not be as, my apologies, skin, like on your actual skin, what you might see. I mean, of course, you're going to see an entrance wound, and you're going to have a burn from where the entrance wound came in, and how, again, depending how bad it is, how high the voltage is, but it will still affect all of those things that we're going to be talking about, like circulation, and we still have to look out for certain things that are very, very important. So we'll kind of depict through the different types of burns, which ones are potentially more dangerous for certain reasons and why, and just not, again, we are not going, this is med-surg. We want to get the gist. We really want to understand and be able to have a good grasp, but we're not going to graduate burn experts. But as I've said many, many times, it's very important to have a good idea how to kind of make the connections and move forward and understand if you do have a patient, or if they have a question, or, you know, the baby. I mean, that's why we have little receptors everywhere, right? To save our lives, homeostasis, so that we know if we step on something, ow, it hurts, we stop. So hopefully we don't continue hurting ourselves, and your body's trying to keep you from death, basically. Okay, so the last thing I want to say before we hit the PowerPoint part is I wanted to review just a couple terms with you that have to do with on your key terms. So the first one is grafting. So there are different types of grafting that we can do for our patients. That's also on your, I did post, hopefully you guys saw the, for your test, I did post the, you know, whatever it's called, the, oh, come on, whatever, the thing that helps you know what to study, the study guide, there you go. So I did post that, and it did talk, it said skin grafts. So understanding that there are different types of skin grafts, there's an autograft, which means self. So that means that if you do have a burn, you are a match to yourself. Doesn't mean that you can't reject your own skin, though. I just want to keep that in mind, as well as your own organ or your own blood. Your body can actually attack itself, and sometimes it doesn't always work. And not everybody knows that. So I think that is an important aspect as well, to not give patients false reinforcement of, oh, it's from your own body, everything's going to be fine, and it's good. And also, I mean, their infection could happen. I mean, sometimes things just don't take. So ideally, though, taking it from your own body usually is going to be, there is a higher success rate. I don't know the exact numbers, but I do know there is a higher success rate when things are taken from yourself, because it's your own body. It's less chance of yourself, if you have a good immune system, from attacking itself. So if, for example, let's say an autograft, if I have a burn, again, we'll just use my arm, on my arm, and there's a specific part that is really, it's just not healing well, and I want it to basically have new skin. So the skin will not be as, like I mentioned, the psychosocial part as well. It's going to scar. It's going to scar. And you guys have all seen how scars usually end up looking, depending on if it's usually like a 3rd degree burn. The scar can be pretty bumpy and very obvious, and can be very affect people's self-esteem a lot, right? Which is very important. We want to help our patients. So we've come up with cosmetic type of surgeries. I don't know if skin graft is exactly quoted on as a cosmetic surgery, because insurance will pay for that, of course, or should, or at least most does, in my experience. But where they'll usually take on a big part of your skin. So usually like on the back area, and that's a thicker part, where the surgeon will basically remove a layer of skin, and that skin will then heal, because they're not cutting out like a big chunk. They're just like taking a graft, if you will. And if you don't know what that means, it's better to see a picture. It's a very thin piece of skin, and then they can put it over to hopefully then, by that time, and they won't do that until blood is circulating, by the way, of course. Why? Because you need blood to circulate in order for the graft to take. So hopefully that graft will take, circulation will begin, and that healing will happen. And the scarring would be much less noticeable. You may have just like kind of just see where the outlining may have been, right? And that would be a much better potential outcome for the psychosocial aspect, as well as getting that blood circulating and all that good stuff. The other one is you can get a graft from a donor who, again, it's like getting a liver or kidney or whatnot. The person has to be a match. And it's pretty much the same procedure. There is more of a chance of rejection, but not necessarily. And there's all, the medications and everything that come with that can help to prevent somebody from rejecting that skin. And not that it's completely important, but that's called so auto always means self, and allogenic means a donor. So I think the most important is to remember auto, like autologous blood transfusion, autograft, because then if you know that's self, usually if it's the other word, usually that means donor. So in this case, it would be allogenic. Okay, then the last term that I want to go over before we start with our PowerPoint and end phase 1 has to do with an escharotomy. So escharotomy, that's another term. I think you have 4 terms, or 3, 4, and I picked 2. Sorry about that. I don't know why it goes dark every once in a while with the screen. It's perfect, and then it's not. So this is something that I think is often confused with where you see swelling, and it's a fasciotomy, and people will then cut open the limb to release the swelling. This is not the same thing. So what this is when somebody's burned, and they can do this on the chest, on the arm, on the hands, on the wherever the burn is, and this is done 3rd, 4th degree burns, not 1st and 2nd. So this is when we're at that point where blood circulation is compromised. And what happens when blood circulation is compromised? We are not getting oxygen. So that is not good. So we actually, it sounds awful. And I mean, I would not want it done to me. Luckily, as I mentioned earlier, though, you usually don't feel pain unless you obviously hit an area where maybe it's a little bit of a less 3rd degree burn. And, but usually the patient is sedated anyway, because in most cases, when people have gone through such a traumatic event, they're in shock, or they're fighting it, or potentially intubated, especially if you're getting this procedure done. And I actually said it correctly, so now I don't want to say it again and mess it up. Escharotomy. If you're getting that done, this is from a fire. So you have been through an extremely traumatic event. Who knows what happened in that event? Who knows, how much pain you went in to get to that 3rd degree burn. So you are obviously hurting at that point, right? Because at that point, maybe the nerves aren't dead yet. This just happened. So usually you get them into the paramedics, into the ambulance, however they're going to make their way to the hospital. and it depends on when they do this, but they want to, physicians, nurses, we want to try to supply that area with as much blood as possible, because that's when the circulation is really, really, really low and will actually start, because it starts to die, right? And we talk about that in the slides, but the blood flow starts to go down, and the more the skin dies, the less chance you're going to be able to graft it, right? Because you need blood to circulate, and potentially that part of the body then will never heal. The healing process is not going to happen, and you're going to have potentially amputations, which is another part to think about too, right? No circulation equals amputations. And you will notice a lot of patients with burns, third and fourth degree, more fourth, but third and fourth degree burns will have amputations if they've gone through that. Maybe they're missing a limb or maybe a hand or whatnot. And that's why. It's because of the circulation of blood has stopped. Okay, so let's do this here. Okay, so basically what this procedure will do is, so if I take a scalpel, and let's say you have a 3rd degree burn on your chest, and you have 4th degree burns on your right leg, let's just say, and then your other leg is a 2nd degree burn. So 2nd degree burn, they're gonna probably put some sort of ointment or something just to keep it moist. And then the other leg, they may take a scalpel, and again, the patient is usually intubated at this point, because a lot of the times when people are in fires with flames, this is the most dangerous part of it and can potentially cause more mortality. The mortality rate will be higher is because of the inhalation of the smoke, and they call that soot. That's why they look in your throat, because the smoke that the person is inhaling, it actually will swell the airway, right? And we don't want that. ABCs, right? Or BA, whatever they're calling it now. I don't care. It's still ABCs to me. So airway and breathing can be compromised. So usually the first thing that the paramedics or whoever arrives first, what are they going to do? They're going to look in that person's mouth down the throat. Is there soot? Do you see that tar, like not material, substance? And is there swelling in the airway? Yep. Get them intubated immediately, get them sedated so that they're calm, and then potentially this usually would be performed on the 3rd, this procedure with the scalpel. And then, so basically a cut is done usually about 1 to 1.5 centimeters below the unhealthy skin. So you'll actually see blood come up. So when you see the blood come up, you know that you're getting circulation. So once that happens, then your body will start circulating blood better. So the hope is that blood will start rushing to that area and actually start the healing process, and blood going to help basically heal what's going on. And that's why they would do this procedure there. So I think that the graft and the escharotomy are going to be 2 things that are really important to understand, and why they're doing it, because these are 2 very, very common things that you're going to hear, and we want to get that perfusion, and we want to get the normal tissue to get blood flow. So just keep in mind, it's not a fasciotomy. It's not cutting for swelling. It's basically wanting your body to have more perfusion to that area that was in a 3rd or 4th degree burn. Not a 2nd degree burn. If you do that, you're gonna get punched in the face, especially if you're not sedated. And you're fine. You're getting circulation in a 2nd degree burn. And then obviously a 1st degree burn, you would just be self-mutilating. I mean, you're cutting your skin for no reason, right? So any questions about that, we can definitely go over on Monday. But I think it's pretty well explained. And if you want to look it up on YouTube, don't eat anything while you do that. Okay, so let's go ahead and share the screen, and we'll start going over the PowerPoint. Also, I wanted to say, I may have, I don't know if I posted it or not, but some of the PowerPoints are from the previous book. It's still the same thing. So if there are page numbers on there, and I did try to go through and I'll erase it. I didn't see any on this one, so I didn't. But the previous one that I did post, it had some of the wrong pages. Same information, just not the right page. Because I have gotten some help I mean, why reinvent the wheel if you don't have to? And then I just kind of added my own stuff. Okay, so nursing care of patients with burns. So let's go ahead and start off with burns in general. Pathophysiology, I think, is fairly clear. We did some talking about that in the before we started going over the slides. And basically, it can be any sort, like I mentioned earlier, any sort of transfer of from a heat source, basically. So it doesn't just have to be fire. It can be any sort of chemical or electrical, even so people who might be rewiring something, they might get shocked and whatnot, and that's considered a burn, again, depending on how bad it is, and all of that will depend on many things. And it can actually render someone unconscious if it's strong enough, just like lightning, right? So what happens here is, I really like this bullet point. Heat denatures cellular protein. So when you have heat, and again, that can be from any sort of fire, chemical, whatever the source may be, it's denaturing the proteins in the cells of your skin, and it's breaking it down. And that we don't want that, right? Because the further it goes down, dermis, lower, muscle, bone, we don't want that. That's when we're going to have circulation problems, and we're going to potentially have more complications. And the biggest thing with anything, right? We want to prevent complications. So we want to think ahead. What can we do now? And that's why we do the incisions, the escharotomies, right? Because we want to try to do our best to bring that perfusion, bring that circulation to prevent potential amputations, and start patients on antibiotics and get them on IV fluids. And we'll talk more about that as we go as well, the fluid loss and whatnot, because as I'm pretty sure this has been mentioned in some sort of way up until this point, is that the skin has a lot to do with fluid balance. So when we don't have our skin protection, those layers of skin, once you get to that third and fourth layer, and that's kind of how I look at it. I mean, you can, however you can put it in your head and help yourself remember. I look at first and second degree burns, or you're at home. Third and fourth degree burns, you're in the hospital. Again, I know there can be a mix, but I'm just, again, for the big picture, that's how I think of it. And you can actually get a second degree burn from the sun. Oddly enough, I was watching a movie this morning. What was it called? It was a comedy, but a woman had put oil on and actually got a second degree burn on her face, and that can leave scarring too. And blisters usually happen with that at that point as well, which are very, very, very painful. Not fun. We've all had a sunburn, I'm sure, and ouch. Okay. So, and then the last part here is the interruption of blood supply, which we've, I think, covered sufficiently. That is very, 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 very important. We want to make sure that all of our body, all of our organs, everything is getting blood supply to it, because if we don't have blood supply, we don't have oxygen on our red blood cells and to be able to travel, and we are at risk for many, 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 many things. Okay. Next one, the alteration in normal skin function. Of course, if we have a burn, again, depending on where it is and how big and what type of burn we have. And that's why it's so important to really get as close to the best diagnoses you can, so that you're able to help the patient, especially if they have comorbidities. Again, we're thinking ahead. What if they're already on like diuretics, for example, so they're urinating more, so they're losing more fluid already. So that could be a critical thinking. You know, we as nurses, we're always looking ahead, and we're always looking at that bigger picture. So the loss of our protective function. I mean, your skin is, as we mentioned the very first day, that's your largest organ. It's very important. It is your first line of defense. And when it is compromised, that can affect every part of your body specifically. And I'm going to read it specific from the book. The fluid balance, cardiac, GI, renal, immune, and pulmonary. And we will talk more about specific ones of these, especially pulmonary, as I mentioned earlier, but that's a little bit further in the discussion. Risk for infection is extremely high. Again, this is protecting you. So imagine, let's say you're making a salad and you're cutting a, I don't know, what do we like to put in salads? A tomato. And you're cutting a tomato and you cut your finger. And you cut it pretty deep because you're not paying attention. You're trying to watch my video, change the baby, do 1,800 things at the same time, and you cut your finger down to the bone. You need stitches, and what could potentially happen? You're at risk for infection. You just opened up a major area of your body that is helping you to not have an infection. So definitely the patient is at risk for infection. So that's why usually they'll do, not usually, I think everything I've ever researched or seen, when you have a 3rd and 4th degree, again, hospital-based burn, that's what I call it, you're going to be on prophylactic, meaning, if you guys haven't heard that word before, I'm sure most of you have, but prophylactic antibiotics would be antibiotics to help you not get an infection, basically. So you're prophylactically, you're doing it before you even know if they have an infection, or they may not, you're not going to have an infection after 2 hours. So we're prophylactically helping you not get an infection as they're putting in IV fluids as well. Change in sensory function, of course, as we mentioned earlier, if you have a 3rd and 4th degree burn, you're not going to feel things the same way. So that's something to think about too. If you don't get that function back, you have to be pretty careful. And that's a lot of, as a nurse, that's patient teaching. You need to explain to your patient, hey, you have a 3rd degree burn on your foot and your left thigh, I don't know, or your hand, you need to really be careful because you may not feel things the way other people are feeling things, and you could actually end up hurting yourself. So you need to, that's patient care, right? So understanding, 3rd degree burn, sensory loss, and so forth. Fluid loss, we talk about in later on in the discussion in a little bit of a deeper capacity of why fluid loss, because that is a very, very important thing. May or may not be on your quiz. Impaired skin regeneration, of course, because your skin, it's fighting itself. You're compromised, basically, right? So the regeneration of your skin, you can't grow something without blood. You can't regrow something if you don't have it. So if skin is burnt away, it can only close so much, right? And that's where skin grafts could come in. And then impaired, basically our glands. So our glands are involved in our skin. We have already talked about that. The integumentary system, it's not just skin, it's glands, receptors, and vascular system, hair, nails, and all that good stuff. So of course, these are going to be involved potentially as well, depending on how deep the burn is. Again, that would be more 3rd and 4th degree burns, not 2nd. And that is going to be an issue. Let's think about temperature, right? Temperature, what do we do when we're cold? We shiver. What do we do when we're hot? We sweat. So that can have an impact on how we regulate our body temperature, which is very important. Okay, so I decided, because I didn't want to forget, so I want to actually just go over this part with you real quick, and not skip it like I was going to. So in relation to the fluid loss, so fluid loss, and you'll see in your book when you're reading it on the first couple pages, it talks about the different areas of the body that are affected. We've already talked about all of them except for, we talked about pulmonary. Immune function has to do with just the fact that your body has, it's been opened, right? So you're gonna be more compromised for infection. Renal's gonna go with fluid balance, and then cardiac kind of just wraps all into that, because we know our renal and cardiac system go very closely together, right? We're gonna have less cardiac output if we have less fluid. So right here it says fluid loss. So fluid loss, okay. Why do we have fluid loss? So when you have cells that are damaged, and as I have mentioned, again, thinking more toward the 3rd and 4th degree burns, and you have these damaged cells, our body wants to do what? Homeostasis. It wants to fix it. It's like if you cut yourself, and what happens? It gets red and inflamed. It's sending histamines. Your body has its own defenses and own mechanisms to help try to make it better. unfortunately, sometimes it ends up making other things worse. And again, this is why we continue to think ahead and watch for what we know may happen. So we have the damaged cells, and then it releases this basically an inflammatory defense mechanism to try to heal your body and help it. And even though it's trying to help it, it hurts other parts of your body system, such as where it says here as fluid loss, because it's going to increase the amount of fluid in your body that's able to leak out. So you have damaged cells, inflammatory defenses come out, your permeability, kind of think of edema, and when like fluid leaks out of it, edematous tissue, let's say your calves they have edema and you can see fluid actually leaking out. So it's kind of a similar mechanism to that. And then you're going to have your fluid leaking out of there. And then you might actually see edema too, as well, because you might see swelling. And then you have water loss much, much, much faster. The book says 4 to 15 times quicker than you would normally have just in, you know, like your normal body system in general. So we know that if that's happening, that's going to affect your renal system, which is therefore going to make it to where you're going to have more insufficiency of fluid in your body anyhow, which causes dehydration, which is why, sorry guys, Violet. And then unfortunately, then we go to the cardiac system, and we know that if we have fluid loss, that our cardiac system is going to have less cardiac output. So that can cause all sorts of issues with our cardiac system as well. Okay, let's go back to sharing the screen. Just had to put my problem child away. And now the other ones are going to start. Of course, right? Okay, so moving along here. So systemic. So what does that mean? Systemic means full body. So what that would mean would be, for example, if I took, if you're not familiar with that word, if I was to take a medication, for example, and let's say I'm taking it PO by mouth, that is not systemic. It will eventually go and be systemic, but in that moment, it's not systemic. It has to go through first pass metabolism and do all that stuff. If I want something immediately to be systemic and automatically hit everything right now, that would be doing like Flonase through the nasal cavity, because you have your mucous membranes there and it goes through your blood system just like an IV would. Just, again, kind of trying to make the connections and put that together. So what systemic response is, this kind of has to do with what we just said. So what happens is, and this is, so I had my way of explaining it. I think this is a better kind of a linear way to think of it, depending on how your brain works. But the systemic responses that your body is going to, unfortunately, be inflicted with on the 3rd and the 4th degree burn will be increased capillary permeability, as I had mentioned, right? Meaning that your body is going to be more susceptible to your capillaries leaking out fluid. So you're going to leak, and remember, your blood isn't just blood. You have plasma, you have proteins, all sorts of stuff. For example, albumin. So if albumin is decreased, which is what keeps basically all of your vascular system where it needs to be, all the plasma where it needs to be, it's a very large protein. If that's decreasing because your body's not able to keep up with it because you have these burns and everything that's happening and it's leaking out of your system, you don't have enough of it to basically keep up, if you will. So who knows, that might be in order that you get a blood transfusion as well, to help with this and help keep blood in, and as well as fluids in, because I mean, we can be pumping you with IV fluids, but if the fluid's not staying where it needs to be, what good is that, right? So again, critical thinking, bigger picture. Loss of intravascular fluid, which is going to cause edema. We talked about that. Decreased cardiac output. We talked about that and why. Why decreased cardiac output? Put the connection together because of that decreased fluid, right? And decreased fluid affects the renal system, and that can actually, unfortunately, create hypovolemic shock. And we know what that is. We don't want the hypovolemic shock, which means we just have so little fluid in our bloodstream and in our body to where we can't keep up and our body cannot function, and we're not able to regulate many of our, okay. All right, so hypovolemic shock, your body's not able to keep up because all of your systems are basically potentially shutting down at this point. So we want to avoid this, of course, because this can lead to death. And decreased platelet function, of course, because we're losing fluid, we're losing all of these things, and at the top where it's talking about capillary permeability, and we're losing all of this stuff that we need that's in our blood. So if we're losing platelet function, then we're having trouble being able to coagulate, which is not good. And then white blood cells, of course, and platelet aggregation. So we, give me just one second. I think I have a thing on here. Nope, I don't. I thought I had a picture of it. So decreased platelet function, and then leukocyte is a white blood cell. So if we have less white blood, or sorry, more white blood cells aggregating, that is potentially going to cause what? Infection. So again, we are trying to prevent that from happening. And oops, excuse me there. We already kind of went over all of this, and this is in your book. You guys know about the, we already talked about the renal insufficiency, the pulmonary damage. I really, I'm just going to say it one more time about the pulmonary damage, is that if somebody is in some sort of fire that has flame, the first thing, what do? You look in their mouth, you look down their throat. Is there swelling? If there is, usually it's intubation right away, not even a question. They just intubate, because once this patient has too much of that happening, the whole entire airway will start basically swelling, including the bronchioles, and then you'll have lung damage, and it's a catastrophic event at that point. The rules of 9, I gave you the video on as well. So you got this little guy here. So in a child or an infant, and then the adult percentages. And, you know, again, as I said earlier, we're not going to, well, maybe some of you are, I don't know, if you're going to go into this line of work, but you don't always have to be the expert and memorize every single thing. Of course, you need to know certain things for tests and whatnot, but having a good understanding, and there's good ways, and I like the way the video kind of helped give a little, not really mnemonics, but like a child's head is bigger, right, in comparison to their body. So you double it, 9 and 18, right? And they gave little things here and there. Genitals are always 1, and things like that. So understanding, I think the most important part is understanding that there's a thing called the rules of 9, meaning it tells you how much percentage of the body is burned, knowing that there's the difference between a child and an adult, child and infant being together, and adult, knowing that there's a different percentage of their body. So if it's their head for the adult, it's going to be 9%. If it's for the child or the infant, it'll be 18%. That's really important. Like, those are the important takeaways. And there's resources. So you can easily look up rules of 9 if you needed to, right? Or if obviously you're working in a place like a ER or a level 1 trauma center or a burn center, it's going to have that information where you don't have to necessarily memorize it. But then if you work there, of course, over time you will. So just, again, I'm trying to take away I want you to take away the big picture, not get so caught up on every single tiny detail, because I want you to remember it. And again, the more you connect, the more you'll remember it. We're not doing that. Let's see here. Oh, okay, so we've talked about this, and this was in the video as well. The depth of burn and how much, and there are different names, of course. The 1st degree burn, I always think of sunburn. It's very superficial. Doesn't mean it doesn't hurt. It hurts, sometimes more than others. 2nd degree burn is, we also call partial thickness burn. It is deeper, and I associate that with shiny and blistering. Ow. And I actually just, oh yay, it didn't even realize it healed, and I was worried because of my tattoo. I'm like, oh no, is it going to come off too? It did not. But if it went deeper, it would probably, right? So that's something to look at. I had a blister, didn't even realize it. I told you guys what happened last time with the long lighter, was lighting something. It didn't even have the flame. It was just the tip of the long lighter. It touched it. It burned like a, you know what? just forgot it, didn't even look at it. Saw it the next day and had a blister. So I had a 2nd degree burn, even though it was like tiny, I still had a 2nd degree burn. And then it popped on its own and now it healed and it's good, but it hurt like a, you know what. And then, so just imagine having that on like your full arm. Wow. That would be pretty intense. 3rd degree full thickness burn. So these are the secondary names that we call, and it makes sense. And to me, it helps me remember. So partial thickness, superficial, partial thickness, deep, full thickness. So it kind of helps me know that it's, I mean, I know we know 1st is the lightest, if you will, and then 4th is the worst. And that's not on this picture because 3rd and 4th are pretty much the same, except what are the difference between 3rd and 4th? The 4th has to do with bone and muscle. 3rd does not, usually. But again, there can be a little bit of mix. So here's just a couple pictures. So 1st degree burn, as I had mentioned, most of us have had. It burns. It burns. It does. It burns. It's sensitive to the touch. Doesn't feel good depending on the person and how, you know, everything has a little bit of a spectrum, how long it will heal. But usually within like 2 to 3 days, people tend to not have it's not as much, as sensitive. And then our 2nd degree partial thickness burns, as I said, is usually blistering. Example of this, I have a friend who actually owns a nail salon. They're open, by the way, if you're interested. But her daughter was eating a bowl of soup, and it wasn't pho, it was some other delicious soup that I've had before. And unfortunately, and she was at the time, so she's just turning 11. So I think she was like 7 at the time. So and she's very, very tiny as it is, but very little arm. And she actually spilled the hot water on her arm and she got a 2nd degree burn. And she does have a little bit of scarring. And on top of that, she has eczema. So poor little thing. So it burned on top of her eczema that she already had. And it looked very similar, I would say, it started off looking more like this. And then her scar is about, I would say, 1/4 of what this looks like. So you can tell that she definitely had an accident, but it did not leave a scar as traumatic as this. And this is, you can tell this is fresh. So this will probably heal if it's taken care of. Okay. So now we have our partial thickness burn, much deeper. This is in the video as well, again. So I know that you already saw this. And it's just, I don't know if I mentioned this earlier, but imagine even, I don't know if you'd call it compartment syndrome exactly, but because we talked about that earlier, it's not a fasciotomy and cutting open for that reason, but a lot of times loss of movement, right? Because nerves and all of those things are happening. So see how this guy's hands here, or yeah, this is a guy, and we see the swelling, we see blistering. So that's what I mean. This is probably, there's probably some 2nd degree burning in here. Like right here, this looks 2nd degree to me. This looks more 3rd degree to me. That might be even a little bit of, who knows, right? So there is definitely a mix, but overall, it's a 3rd degree burn. And this, I don't know why a child was picked for this picture. I don't like it. I forgot to switch it out, but it, you know, this happens. So I guess taking a look. This is a 4th degree burn. And as you can see, it's pretty clear and it's a lot of the body. It's, I mean, almost from what I can tell, I mean, just guessing, I mean, that's about 80-something%. So you can see here, they probably did what we talked about earlier to create circulation, because you see black equals death, right? Necrotic, and burn, which is burning away. So it's just falling off that tissue. So this would be considered our full thickness 4th degree burn, which right now doesn't hurt. But as it's healing and nerves are maybe starting to get feeling back, pain will start to happen. Just keeping that in mind. I did not mention that earlier. We may actually do this all in one swoop, actually, so I don't have to do 2 videos. So etiology, we talked about earlier, but let's just go over it. Flames, so we know what fire is. Contact. Contact to the fire, or chemical or electrical or radiation. So and you can even, so I think what they mean by contact here, I don't know why I missed that when I was going over the PowerPoint, would be like if somebody were doing something electrical and you happen to be touching them, that current can go through them to you. It may not be as strong to once it gets to you, even like lightning, for example. If you happen to be holding hands with your significant other and you're taking a walk and your significant other gets struck by lightning, that current will go through them to you, just as a side note, if you didn't know that. So these are some different ways of how burns can be created. And now let's, think about it for a second. So if I have somebody who has an electrical burn on their hand, am I gonna immediately check in their throat? No, I'm not. If they have an electrical burn near their face or their head, am I going to? Yes. I'd probably look at their throat anyway, because maybe I don't know what happened, but I'm trying to really get you to focus on the fact of flame fire. It's the smoke inhalation that is going to be the most mortality and death because of that. That's going to potentially cause more complications. So I really, really want that in your head. Okay. Diagnoses. Oh yeah. Okay. So lots of tests. So we talked about all that stuff that can happen earlier, and how it's a catastrophic thing, right? It goes from one thing to the other. Okay. The permeability, then the renal, and then of course, if your renal's influenced and your cardiac can be influenced, if you have a secondary issue, if you have diabetes, if you have this, there is just a plethora. So we need baseline everything. Baseline. So of course, we're going to do a history and physical once everything is stable. We always run CBC. That's for sure. I definitely want to run kidney, renal labs as well. So BUN. I might even run. It says here urine cultures. I would do creatinine. I want to know everything. Glucose definitely, to see how they're doing, because they're again losing a lot of electrolytes. There's, as I mentioned earlier, the albumin. I want to know how their albumin's doing, because if they have low albumin, that is going to put them more at risk for dehydration, because remember, albumin, which is held and created and stored, and basically the liver is what houses that. If it's not doing what it's supposed to be doing, you're going to be losing even more fluid. So again, possible blood transfusion, clotting studies, x-rays, EKGs. I want to see what's going on internally to the body as well, because all of these different parts are being affected and I can only see the outside, right? And then of course, all of these will be redone to get your baseline and then see what's going on so that you can implement interventions to help these things happening. Okay, therapeutic interventions. We've talked about, pain control. We didn't talk about that. Yeah, definitely. So ABCs we mentioned. Stopping the burning process, we didn't really mention, but by the time they get to you, more than likely that's, I would hope that would be done, unless you're on the scene for, whoops, I apologize, for whatever reason. Stabilizing any related injuries, like if maybe it's a car accident and there was a fire and a potential partial amputation, and making sure that we're getting a tourniquet or whatever we might have with us to help blood loss, or whatever we can do in the moment to help with the patient, CPR, whatever it may be. IV fluids we mentioned, and of course pain control. I have no idea. Me, right? The one that is trying to, anyway, pain control definitely is important. Usually, like I mentioned, sedation would be something that we would do or anti-anxiety medications, benzodiazepines, Ativan, Klonopin, Valium, things like that. But we have to be careful because of respiratory depression. There's a bunch of things that we have to look at. So of course we're going to start small, but we definitely want to help control pain. Because remember, even though you have a 3rd-degree burn, it's still going to hurt in the beginning, right? Because your nerves aren't dead yet. So there are several different ways that we can basically, we talked about the biggest one that I've seen. Depending on the wound itself, of course, we are going to take care of it when our patient is in the hospital. That's our job usually as the nurse, because we're going to be doing the assessment. We're going to take a look. How's it healing? How's it doing? Do you feel pain? So that we can document that. How are you doing? How is it getting better? Is it healing? Are you getting sensation back? So there might be dressings included. We're always looking for potential infection. Skin grafting, we already talked about that in detail. Controlling the pain, of course, when are we going to give the pain medications? Probably about 45 minutes before we do the dressing change, right? So that the patient, well, depending on how you're giving it, PO or IV. IV is like 10 minutes. And then maintain nutrition. Of course, nutrition, as I mentioned before, is like medicine, right? I mean, protein, healing, getting that nutrition into your body to help your body be able to heal from the inside out, as well as fluid and electrolyte balance. It's very, 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 very important. And then always monitoring for complications. So if someone did have a skin graft, is it healing? How does it look? Documenting, communicating with your team, all of that. Skin grafts, again, we already talked about this, is an autograft, which means, again, from ourselves. They took it from a different part of the body, and then they put this kind of I don't know what it's called, but it's like a netting almost that they put over it, and then everything kind of congeals together, and hopefully the graft takes. Here we go. Oh yeah. So there you go. There's that picture. I missed this. Oh, I only went through 17 of the slides. I didn't even, oh, there's 29. Okay, well, here we go. So this is the escharotomy, which again, we do to help with perfusion for 3rd and 4th degree burns, because we are losing circulation. We want to make sure that we go about 1 to 1.5 centimeters below where the burn is, so that we can see blood. See, do you see here how we're seeing the blood leak down? That's good. We want to see that, because that means that now we're having circulation in that part of the body, and hopefully we're preventing things from happening, like amputations. It could be other things. I'm just trying to, I've been talking for a long time, so I don't want you not to finish this. The rehabilitation stage, it's hard, and we're going to talk about this on Monday. We're going to do our new way of teaching on Monday. So I'm going to come with some questions. I'm going to have a short video on the psychosocial aspects of burns, going through the reconstruction process. I mean, imagine yourself right now, you're in nursing school. I'm just making up a patient, 24-year-old female, happy-go-lucky, just living your life. Everything's great. And then one day you know, tragedy strikes. I mean, your house catches on fire, and then all of a sudden you have 50% of your body, including parts of your face, with a 3rd degree burn on it. And now you have to go through, I mean, I can't even wrap my head around how that would feel. And I'm not saying, in my nursing opinion, it's not about being pity and, oh, you poor thing, and this. No, it's about having that empathy, not sympathy, in my opinion. So understanding all of these things that could potentially happen. We talked about preventing contractures, again, you know, so physical therapy, moving around. And then they have these special baths that they do, may or may not be on your study guide. So I tried to make this as broad as possible to see different things that we can do to help, but as narrow as possible to be able to remember and kind of know what's maybe the most important thing to remember as we go on in our career. And everything I'm talking about right now, I pretty much looked over this maybe for an hour. So this is all stuff I remembered from when I learned this, and we don't learn this continuously. I only learned this up until LVN or VN school. So this is all just stuff that I remembered. So that's kind of my why I do things the way I do. I won't say which teachers I learned it from, but some very good ones. So contractures, we know what that is. Working in skilled nursing facilities, not getting a lot of movement. In this case, it looks like there's some swelling going on as well. So we really want to try to do physical therapy so that that doesn't happen in doing movements, because we want to keep as much function in our limbs and hands and body as possible. And our skin tends to get tight too when we have 3rd and 4th degree burns. So we want to try to do our best to prevent that. This guy looks like he's on the mend. So there's, of course, different nursing diagnosis on everything we talked about, from the breathing to we want to make sure turning our patients, they're much more compromised. So they're going to be more compromised potentially to get, like we said already, infection, different ulcers, right? If you're laying down all the time, elevating the head of the bed to help potentially with oxygen exchange, as well as getting in those deep breaths and using the spirometer as well. These are just nursing diagnoses that I think everyone's pretty familiar with. And do not apply ice. Why? That's going to be a question on Monday. And that will be posted too. And it's not in your test, so don't worry about it. Do not apply ice. I'm writing it down. So I'm coming with about 7 to 10 questions on Monday for us to talk about. So that's going to be one of them. Why don't we apply it? Because that seems like, oh my God, yeah, apply ice. Let's do this right now. So with this nursing diagnosis, impaired skin integrity, of course, we know we're going to assess the burn, remove any clothing or jewelry that we can. And why? I'll just answer that right now. Because of swelling. So, I mean, if you have a ring on and then all of a sudden it starts to swell, that cannot be good, right? So we may even have to cut it off depending on how the swelling has already started. All of this we pretty much talked about. Almost done here. Impaired skin integrity, protect self from chemical agents, of course. Usually there's procedures and protocols if you're in the workplace to help prevent these chemical burns from happening. But accidents, of course, happen, right? And then they have like stations or whatnot and of what to do, and then call I almost said the police, call the ambulance and get the patient to the hospital as quickly as possible, so we can do what we need to do to hopefully prevent. We may need to debride. What does debriding mean? That's going to be another question I'm going to ask. It has to do with the skin and healing, and potentially, well, not potentially, we're going to, of course, apply dressings, and depending on what's going on with the patient, what type of dressing and where it is, and where they are in their healing process. Dressing principles. I think we pretty much already have gone over this. I think the only thing on here that it would probably be the most important, and this is going to be another question, is never wrap skin to skin. So we're not going to take, let's say, our material that we're going to wrap onto a patient. We're going to put a barrier, basically. So why a barrier? Like gauze or something. Why a barrier? Why barrier when wrapping burns? So that's going to be another question. I might have like more questions than I thought it maybe going to have on Monday, but that's good. That's good, because we want to get you thinking about these types of things, like why. We want to know why we're doing what we're doing. We don't just do things because that's so it's always been done, or that's the order. Why? I want to know why. And what if my patient asks me why? And I'm like, I don't know. I mean, of course, you should know. And you're human. So if you don't know, like I said, we can always say, oh, you know what? Let me find out. I believe that the order was changed because of this reason or that reason. So I'm not trying to be mean. And then elevate extremities. Of course, we know why we do that. Perfusion. We, of course, very, very important, monitor weight and INO. Why? Because of everything we just talked about with the dehydration. And then we're going to continue to do the testings to see how we're doing. Are we improving? What else do we need to be doing? And just perform any orders. Every patient's going to be different depending on their burn, how they were burned, what type of burn, how much of their body was burned, child, adult, other medications, comorbidities, all that stuff. Pain, definitely want to manage that. It hurts, as we already know and we talked about. So monitoring pain and keeping the environment as comfortable as possible, and giving that therapeutic touch if possible. Not touch like actual touch, but therapeutic touch to the patient. Hopefully, trying to be a bright spot in their day, if you will. I didn't exactly say this, but we mentioned amputation. So really watching the pulses as well is really important when we're doing our physical assessments for perfusion, which we've talked about. So making sure that we're checking all of the pulses, not just, oh, okay, I'm gonna check here. No, I'm checking all the pulses, making sure we're perfusing, we're having blood circulation, and asking about, can you feel this? Can you feel that? Because we need to be able to tell, because we can't always see everything, right? So we need objective and subjective data. That way we can tell, it is starting to heal. Oh my God, they didn't feel anything and now they feel tingling. That means the nerves are starting to regenerate, which is amazing and great. That's what we want. Everything on here we've already talked about, except apply dressings loosely, which will be pretty much goes with the other question I'm going to ask on Monday. And of course, we don't want to tighten. Number one, it's going to hurt as it's healing. And number two, we don't want to cause, it's already potential for swelling, right? So we don't want to cause more swelling and potentially kind of like compartment syndrome, if you will. And help, it can decrease circulation too. So risk for sepsis, that is our goal, is to prevent sepsis. That is basically, if we're over here and this is day one of patient, we're avoiding this over here, hypovolemic shock, sepsis, and then in between are all the potential complications. So that's what we're trying to do. So that's why we're always looking for infection, checking everything. We're repeating things so often, but things can happen so quickly with burns, especially with, as we've been talking about, the flame burns with the 3rd and 4th degree. And then, as we mentioned earlier, administering immunosupportive medications, depending on what's going on. Are they having grafts done that can support the grafts? And we talked about antibiotics as ordered, and usually it's prophylactic, or a physician or NP or PA they'll prescribe something that's specifically, there are medications that are antibiotics that are more specific. Like if you get a UTI, everybody knows, oh, you get Cipro, right? So they'll prescribe something, or if your patient develops maybe a staph infection or something, then they may change the antibiotic order or whatnot. And of course, the pain medication. So it looks like we actually did finish this all in one. I feel, I'm just gonna put you on hold. I'm gonna pause this and just double check my book to make sure I didn't forget any of my notes. Just one moment. Nope. It looks like that Miss Lynn did a great job with that PowerPoint. So we actually got through everything. Everything I wanted to say in the beginning. I got 3 more questions for Monday. I just need to find some NCLEX questions. And then I have my psychosocial video. So we'll be online, and then of course questions on Monday, probably from anywhere from 45 minutes to an hour for questions, me asking you questions. And if anybody else thought of any questions that they want to ask the class, and I might do one patient scenario as well. One patient scenario. Okay, awesome. Well, I hope this was helpful. Again, you guys have your videos. You have this lecture, and then we have Monday. So with our new method of what we're going to be doing, and then again, that will be posted. And I will do an announcement when I post it, because people that haven't been on there don't probably know that I will be posting it, so that they'll get to see it too. And good luck on your test on whatever day it is. Your quiz is today. It's about to open pretty soon. It's open for 24 hours, and then your test opens Monday to Wednesday, I believe it is. And I did it that way because clinical is just crazy, and you have 75 minutes to do it. I wanted to make sure that there was enough time. So take it as you wish. And like I had mentioned, as we move forward, you know, things might get a little bit more stringent, a little bit more, it depends. It just depends. We're just trying to be flexible, or I am, because I know that a lot of you have clinical and this and that and everything is kind of all over the place, but you need to sit down and take the quiz all at once. And so that's why I didn't really care that it was open for a little bit longer. So anyway, if you have any questions or need anything, go ahead and email me, give me a quick text, and everything should be up and working. I double check the quiz and the test. I always do it 3 times. I do my best. You will on your test, please do not freak out. Your score will look probably much lower than it really is, because I did, I think, only 2 select all that apply, and I did like 5 short answer. And those will not, the short answer ones will not come up. So it's gonna, and I'm giving you multiple points for those. So like 3 points rather than, or 2 points rather than 1. So it's gonna look like you didn't do as well as you did. I will go in very, very soon, and then like I did with the last quiz, which I actually did wrong the first time. If you notice, go back, I did it right the second time. I didn't know how to do it because I'd never done it before. So, okay, I'm gonna end now, and if you need anything, let me know. I'm going to stop the recording, download it, and get it to you guys. I will see some of you Monday. Thank you.